Just so you know, we're going to be recording this. We have two great papers that we will be discussing today. The first is sex-related disparities in intervention rates and type of intervention in patients with aortic and peripheral artery disease in the National Inpatient Sample Database. And we have three of the authors here with us to help us discuss this paper. Catherine McGinnigal, Samantha Mintz, and Paula Strassel. In addition, we have outcomes after transfemoral carotid artery stenting stratified by pre-procedural symptom status. And we're lucky to have the first author, Yoel Solomon, as well as Dr. Schimmerhorn, who are going to be joining us. The articles are being presented today by our two host institutions from SUNY Upstate, Dr. Palma Shah, and her first-year fellow, Dr. Francisco Cardinelli. And then from the University of Alabama, Dr. Danielle Sutsko and Dr. Juliet Blakesley Carter, who is a third-year vascular resident. As I mentioned, the authors that are joining us to discuss both papers from a number of different locations, so we're very excited about that. And then the second paper, Yoel Solomon and Dr. Schimmerhorn. We also have two guest discussants who will be helping us to go through the chat and answer questions as well as review those. Darwin Eden is the Chief Science Officer from Vascogenesis. He's previously at the University of Chicago. And then Jerry Goldstone, who is an adjunct professor from Stanford University. Just a couple of housekeeping things. Please keep your microphone muted. We may call on you to unmute your microphone and ask your question if it's a little bit complicated. But please add your questions to the chat. The discussion leaders will call on you potentially, or they'll bring up your question for you. As mentioned earlier, the event is being recorded. And then the July JVS Journal Club will be set to be on July 14th at 7 p.m. Eastern. The two host institutions for that will be the University of Rochester and St. Louis University. So on that, I'll stop sharing my screen and we will start with the article on disparities and go from there.
Thank you very much, Misty. Just expand that. I'd just like to thank Dr. Glebesky, Dr. Lawrence, Dr. DeMuzio, and Dr. Humphreys for the opportunity to co-host this incredible educational event that you've all been working so hard to do, and it's been so successful. So thank you very much for that. We're very excited. Today I'll be focusing a little bit on just the overview for sex-related disparities in vascular disease. And really, this is nothing really that new. In 1997, the American Heart Association launched their first campaign for women, which ultimately resulted in a decrease in death rate from coronary artery disease by 50%. Those results were published in 2011. Even more recently this year, there's basic science research still looking at the impact of estrogen in attempts to elucidate the underlying mechanisms underway that are working in this capacity. We do recognize that there's such disparities in recruitment for clinical device trials. And even with COVID research, it's been identified that not accounting for sex differences is problematic. Jean Starr and Vivian Halpern identified that there are differences with respect to abdominal aortic aneurysms in women, and they published this in 2013. And then Dr. Mayor and others have also looked at symptomatic but not asymptomatic women having higher stroke rates, comparing this to men after treatment. Furthermore, Dr. Schimmerhorn is here, but his article, but this group looked at the VascuNet, International Consortium of Vascular Registries, and identified differences. And I was incredibly fortunate to participate in Linda Harris's first Women's Vascular Summit, which was the basis upon which this article was initiated. And that was an incredible experience. And subsequently, they've published this book that was just released, and I applaud them for that. So in saying that, I will defer to Dr. Cardinelli to perform his presentation.
Good evening, everybody. Let me share my screen. Hey, so thanks everybody, to everyone involved for making this possible, and thanks for the privilege of presenting this article titled Sex-Related Disparities in Intervention Rates and Types of Intervention in Patients with Aortic and Peripheral Arterial Diseases in the National Inpatient Sample Databases. The objective of the study for the author was basically the need to improve care and outcomes in female patients, especially after the Women's Vascular Summit that Dr. Shaw mentioned in her presentation, which did highlight sex and gender-related knowledge gaps in vascular disease diagnosis and treatment. And with the objective also to provide data on sex-related disparities in the treatment of the three major players of vascular disease, which are abdominal aortic aneurysms, carotid artery stenosis, and peripheral arterial disease. In terms of the methods used, so basically the data was gathered by looking at hospitalization data pulled from the Healthcare Cost Analyzation Project, the National Inpatient Sample, or NIS. We're basically looking at all hospitalizations in adult patients between the years 2000 and 2016. Patients diagnosed with AAA carotid stenosis or peripheral arterial disease that then subsequently underwent some form of vascular intervention, which basically resulted in about a little over 1 million hospitalizations overall that they looked at in the study. The US Census data and NIH data was also used to come up with the sex stratified data and for estimates of disease prevalences. And then Poisson regression was used to look at sex stratified rate of surgeries and incidence rate ratios. As far as the results go, based on the data gathered between 2000 and 2016, there were a little over 1 million hospitalizations for adult patients that required vascular surgical intervention for the diagnosis of AAA, carotid stenosis, and PAD. Since this is looking at disparities between the two genders, with regards to female patients, the really significant demographics that were highlighted in the study were that they present, as far as when they presented, they were female patients were older than their male counterparts, about 71 years of age versus 69 years of age for male patients. They were found to be less likely to have private insurance, 18 to versus 23%, and they were less likely to have coronary artery disease as a significant comorbidity when compared to male patients. After accounting for disease prevalence, what was apparent was that females were about 25% less likely to undergo surgery for AAA and about 30% less likely to undergo surgery for peripheral arterial disease. Whereas very minimal difference was noted in the treatment rate between males and females for carotid artery stenosis. And as you can see from the graphs, these results were pretty consistent over time, over the 16 years of the examined data. And again, comparing females to males after appropriate adjustments, it was noted that females were less likely to receive an endovascular procedure for AAA or carotid stenosis as opposed to an open procedure, but were otherwise more likely to receive an endovascular procedure for peripheral arterial disease. And as you can see again from the graphs here at the bottom of the slide, these results were also found to be pretty consistent over the 16 years of examined data. In terms of the limitations of the study, the prevalence estimates for AAA, carotid stenosis, and PAD tend to be speculative because of occasional presentation with the typical symptoms and sometimes undiagnosed, especially in the female population. The procedure counts may be overestimated because of an inability to assess for the presence of any repeat procedures in the data set, although repeat procedures are really uncommon for AAA and carotid stenosis, especially compared with the overall low rate of surgery. Procedures, because this is an inpatient, hospitalized patient data set, procedures in the outpatient settings are not captured, so we're missing that part of the data. Another couple of important things: in 2015, we had the switch from the ICD-9 to ICD-10 coding system, so some discrepancies may be seen due to that. And the NIS itself also changed the way it sampled its data in 2012, where it went from stratifying random sample of hospitals to stratified random sample of hospitalizations. So, I mean, it's evident there's a lot of studies out there that have outlined sex-related disparities in healthcare in general, but also in presentation, management, and outcome in several diseases and conditions in many different disciplines. And vascular disease, vascular surgery is certainly not different from any of the other ones in this matter. And so the goal to expose these sort of disparities is meant to lead to improved outcomes. And the other thing that's notable is that female patients are overwhelmingly underrepresented in several randomized controlled trials and several other studies looking at AAA, PAD, and cardiac artery disease in general. So there really needs to be further investigation into sex-specific issues, especially for AAA and peripheral artery disease, given the disparities seen in the treatment ratios and the modality of treatment that we saw was shown in this article. Because females, tend to be relatively unaffected compared to males by AAA, for example, but the growth rate for the AAA is faster, and they're more likely to rupture at smaller sizes. And there's also some evidence out there that suggests that estrogen may have a role in protecting premenopausal women from development of AAA as opposed to postmenopausal women. There's also evidence that describes the efficacy of lower extremity revascularization for peripheral artery disease. That evidence is widely available and we know for a while, but it's been largely derived from predominantly male study populations. And so, we saw in this article, women tend to be less likely to receive a surgical intervention for this problem, despite the fact that the prevalence of this disease is similar to that of male patients. And it's also important to notice that females tend to present with more atypical symptoms. They present later, like we mentioned before. And there's some papers out there that show that they're more likely to present with the chronic limb threatening ischemia. So peripheral disease in females, as suggested by the authors of the article, should be approached with a very high index of suspicion, should employ very liberal use of screening, as well as aggressively promote risk factor modification. Again, like we saw in the vascular interventions, tend to be more likely performed in female patients for peripheral artery disease as opposed to for AAA and carotid stenosis. So basically, in conclusions, like I mentioned before, female patients have been noted to undergo to be less likely to undergo intervention for peripheral disease and AAA, and this is with accounting for sex-specific prevalence estimates. They're less likely to undergo endovascular intervention for AAA and carotid stenosis, but they're more likely to undergo endovascular intervention for peripheral artery disease. And they're definitely underrepresented in some of the major clinical trials that have to do with any of the three major players of vascular disease. So it's that makes it a little bit more difficult to generalize treatment guidelines for these patients. So there's certainly a need for further randomized trials involving the female population, or specifically to the female population, to improve technical decision-making, treatment efficacy, and outcomes in this patient population. So that's all I got, and I'll hand it over.
I can make some comments off the bat. First of all, the CDC in 2013 identified that really women are doing pretty well when it comes to AAA, with a 0.07% rate of death out of 1,290,000 deaths, and 0.07% was almost half of the 0.13% of the men. So overall, I think vascular has been managing AAA as best as it can, and women are actually doing pretty well from that statistic. They're 50% better. But I have some particular questions related to the methodology of this paper. The first one, Francisco, first of all, your presentation was excellent. The first issue relates to the statement in the paper of how they calculated the number of US adults with AAA, stent, and PAD. They used sex-stratified US Census data, but they also said they used sex-specific population disease prevalence estimates from the NIH and from AHRQ. Now, the problem is, if you look at the references for those data, the one for AAA comes from Dr. Schemmerhorn's paper, and that data comes from the UK, Denmark, and Australia, and showed that the estimate of overall risk was 1.7 to 4.5 in men versus 0.5 to 1.3 in women. So that's a spread, and those will affect the statistics. The second issue was with PAD. They found the prevalence was equal between the two sexes, but that data was drawn from 2,100 participants aged 40 and older from the 1999 to 2000 National Health and Nutrition Examination Survey. In that survey, the PAD was defined as an ABI less than 0.9 in either leg. And the prevalence among adults aged greater than 40 in the US was 4.3, which is quoted in the paper. However, those over 70 had a prevalence of 14.5%. Then when we go to the carotid, that was particularly interesting because their data came from the Tromsø ultrasound study in 6,000 in Basel, Switzerland. And Basel, Switzerland's population is not really representative of the United States. For one, they have higher aneurysms, but I don't know what their incidence of vascular disease is compared to ours. So if you look at the source of that, you basically introduce significant error in the calculation of the number of women versus men that are having the estimate of patients having interventions for these diseases. So maybe the authors can clarify that confusion, because in one area it says it's from the NIH, but in the references it looks like it comes from overseas. So I would start with that question.
Hi, this is Kate McGinnigal. First, thank you so much to have me on. It's a real honor for all of you to have read the paper and have taken the time out of your evening to discuss it. I think you've highlighted a really important point, and that is epidemiologists don't pay attention to vascular disease. And it is close to impossible to know the true prevalence of vascular disease because across the board, it's completely understudied compared to other more common diseases. And so the best that we can do is use the data that is published on AHRQ, and then that doesn't even completely publish reasonable data. And we had to go to some other websites deep in the NIH and use the papers that we used because there's nothing better that we could find That being said, for aortas, for instance, the way that we did the analysis was to use the most conservative estimate, meaning the one that had the least prevalence for women. And we compared that to a range of different prevalences in men. And all of the data that we present, we thought was the best estimate that we could find. And I would encourage any of you to get involved in epidemiologic studies so we can actually know who we're supposed to be treating. But in general, everything that we've presented here is the most conservative possible estimate and does not overestimate the prevalence of disease in women. You'd also mentioned that women were doing really well in not dying from aneurysms, which I agree with, and I think that's excellent. However, the guidelines are the guidelines, and there's a few questions in the chat box here. Dr. Bush asked, when should we actually offer treatment to women? And I mean, I think the honest question to that is we don't know. We haven't really studied that, and the guidelines are based in large part off of men. But we do know that women have smaller aortas, and we should probably be treating aortas at smaller diameters. But we use the guidelines, and based on guideline definitions, we undertreat women. Dr. Muzio put a question in the chat that said when EVAR devices were still 27 French, it was difficult to offer EVAR. And I agree with that, but open aortic surgery is a really fun thing to do. And that should have been offered, you know, before the low profile devices, and we weren't doing that either. And so I agree there's wiggle room in the estimates, and they are just estimates, but I think there's still a pretty profound problem.
I got a quick question. Can you hear me?
Yes.
Does hospitalization for vascular surgery mean they definitely had vascular surgery when you did the count? Because it affects the statistic. In other words, what is the accuracy of that particular measure? Because you're using a Poisson distribution.
The hospitalization in the NIS with any of those codes as their primary diagnostic code and their CPT codes means that the patient at least went to the operating room. If they went and they had an aborted operation, then it would still count as being an operation. And again, that would make our estimate more conservative rather than less.
Okay. Any other questions?
Misty had a question about whether other factors that may have been adjusted for besides sex that showed significance in the data set. Kate or anyone?
I think the short answer to that is no, but Sam, feel free to contradict me there.
No, I think that we were trying to focus on the specific question rather than going quote unquote fishing for more, because we do know there's a lot of disparities based on race and ethnicity and other variables that have been discussed using the NIS. And so we were really trying to just focus on the question of this project.
I got a question about the institutions because it says it's community hospitals in the United States. But a lot of vascular surgery goes on at university, county, state, and VA hospitals. Are those not in this data set? It sounds like they're not.
They are. NIS has everything except for the federal hospitals, so the VA data and rehab facilities and things like that. You can correct me if I'm wrong, Kate, but that's what I've always written about NIS.
No, you're right. The NIS includes 96% of hospitals in the country, excluding the VA and some different hospitals on military bases.
We can take one more question. I know Ruth had a practical question, maybe be quick. She said she transgender woman, male to female on estrogen, who'd been on that a couple of years ago. The order was 4.9. How would the authors counsel that person now? It's a tricky one.
Yeah, thanks for the easy question, Dr. Bush. You know, I think that, I mean, the really honest answer is that I don't know. And I think that Similar to all of the shared decision-making that goes along with asymptomatic carotid disease and claudication, there's a lot of gray in the data we have, and a lot of our guidelines are based off of pretty old or low quality data. And that may be driving some of this, right? Like we know when you have a large aneurysm, it needs repaired. We know when you have CLTI, you need to be revascularized. But there's a lot that we are not so clear on, and how we choose to talk about it and how women take in that information and what their value system is may be different, and that may be driving some of the treatment decisions. And so in this transgender woman on estrogen with a 4.9 millimeter aorta, I guess I'd have her come back in 6 months with another scan and talk to her about the gray area.
There's another interesting question here from Dr. Anya Ayala, who congratulated the authors on the paper and wanted to know if there's data related to the gender of the admitting physician or attending surgeon. Did you investigate any bias in that respect? It's very interesting.
I think you just signed yourself up for the next Women's Vascular Summit. That'll be an interesting question to look at.
And I just want to put a plug as far as the SVS PSO diversity committee. That's part of what we're working on for the VQI, is to start gathering that kind of information. And we're trying to come up right now with what kind of variables we think would be interesting. And so is the gender of the treating surgeon something we do want to know about for these kind of studies?
So we'll give Paul's last question, I think, and then we'll move to the next paper. He wanted to know if there was a difference with female AAAs and the presence of thrombus.
That information is certainly not in the NIS, and off the top of my head, I don't know of a paper that looked at that specifically. Oh, and then I do just want to highlight that Dr. Strassel, who's the epidemiologist on this paper with us, she's on the chat. And she says that racial disparities could be studied using the NIS. And unfortunately, this is a database of hospital discharge records, so there's no information on the admitting physician or surgeon. Implicit bias, the impact of surgeon gender would definitely be an interesting one to look at. So it looks like she's signing up to be at the next Women's Vascular Summit as well.
Well, thank you very much. It's always great to hear the questions and what comes with some of these articles. We will move to the next paper. Dr. Sutsko will be introducing the outcomes after transfemoral carotid artery stenting stratified by peri-procedure symptom status.
All right, can you guys hear me okay? All right, good evening, everyone. I just want to thank Dr. Glowicki, Dr. Lawrence, Dr. Humphreys, and Dr. DeMuzio, as well as the SVS for the opportunity to be a part of tonight's events. We're pretty excited to be here. I wanted to start off by going back through some main clinical trials that have really established our contemporary practice for the treatment of cerebrovascular disease. 30 years ago, in 1991, the North American Symptomatic Carotid Endarterectomy Trial, also known as NASET, looked at symptomatic patients defined within 120 days and looked at their 2-year stroke rate and found that the stroke rate for carotid endarterectomy was 7% compared to 26% with medical management. In 1995, the asymptomatic carotid atherosclerosis study, also known as ACAS, looked at asymptomatic patients looking at the 5-year stroke rate that found that the carotid endarterectomy had a rate of 5.1% compared to 11% for patients treated with medical therapy. Following these trials, carotid endarterectomy became the recommended treatment for patients with significant carotid artery stenosis. Then in 2010, the carotid revascularization endarterectomy versus stenting trial, also known as CREST, compared patients undergoing carotid endarterectomy versus transfemoral carotid artery stenting and found that the stroke rate for carotid endarterectomy was 2.3% compared to carotid artery stenting at 4.1%. This triggered recommendations for carotid endarterectomy over carotid artery stenting unless patients were considered too high risk for carotid endarterectomy. Although the new revised guidelines should be coming out soon, the 2011 SVS guidelines were published with the following recommendations. They recommend carotid endarterectomy for asymptomatic patients greater than 60%, as long as they have a 3 to 5 year life expectancy, and a perioperative stroke and death rate less than 3%. They also recommend, when possible, to perform a carotid endarterectomy for patients greater than 70 years old. And carotid artery stenting should really be reserved for patients who are symptomatic with high-risk features such as tracheostomy, prior carotid artery endarterectomy, neck radiation, or a high lesion, among other risk factors. Finally, the Roadster trial, or reverse flow used during carotid artery stenting procedure, utilizing transcarotid artery revascularization, also known as TCAR, looked at symptomatic patients greater than 50% and asymptomatic patients greater than 70%, undergoing a new procedure that used reversal of flow instead of needing an embolic protection device for carotid artery stenting. This procedure also introduced the benefit of a direct cut down on the common carotid artery so that traversing the aortic arch with sheaths to deploy a carotid artery stent was avoided altogether. And while promising, there are still CMS criteria for coverage of this procedure, as you can see here. While all these interventions became available to us, the medical therapy has also improved, making it difficult to determine who are the patients we should be operating on, how can we best assess their perioperative risk to help inform our preoperative discussions, and how we should stratify them in future studies. All of these studies classified patients as either asymptomatic or symptomatic. However, we all know that we see patients in our clinics who have a remote history of amaurosis, TIA, or stroke, and these patients likely are not the same as truly asymptomatic patients. Just as we all know that not all symptomatic patients are the same. In fact, Dr. Pothoff and Dr. Schimmerhorn have previously published their findings on the higher perioperative 30-day stroke and death rate in symptomatic patients undergoing carotid endarterectomy compared to those who were either asymptomatic or patients with pre-procedural ocular or hemispheric TIA. This brings up the discussion of patients being stratified by pre-procedural symptom status for transfemoral carotid artery stenting, which is already under scrutiny by many societies when it comes to recommendations for utilization, and is the very thing that Dr. Solomon and Dr. Schimmerhorn and colleagues report in tonight's journal article. And with that, I would like to turn it over to our all-star third-year resident, Dr. Juliet Blakesley-Carter.
Well, thank you, Dr. Setsko, for that introduction. As mentioned, my name is Juliet Blakesley-Carter, and I am a current first-year research resident at UAB. Before I begin, I would like to echo Dr. Setsko in thanking the JVS Journal Club leadership for the opportunity to present. Within the historical context presented by Dr. Setsko, the aim of this study was to evaluate contemporary real-world perioperative outcomes following transfemoral carotid artery stenting, stratified by specific pre-procedural neurologic status. This was a retrospective review of prospectively collected VQI data, looking at adult patients undergoing transfemoral carotid stenting for the treatment of atherosclerotic disease between 2016 and 2020. Included patients had complete pre-procedural data on ipsilateral neurologic status. Patients were excluded for incomplete data, a history of vertebral basilar events, non-atherosclerotic pathologies, and concomitant intracranial procedures. Patients were classified into 3 categories based on pre-procedural ipsilateral symptomatic status. Asymptomatic patients were defined as having no known history of symptoms. Formerly symptomatic patients experienced symptoms more than 180 days prior to their procedure, and recently symptomatic patients experienced symptoms within 180 days of their procedure. Recently symptomatic patients were further stratified into 3 categories based on specific neurologic injury. Recent stroke was defined as ocular or cortical symptoms lasting more than 24 hours. Recent hemispheric TIA was defined as ocular or cortical symptoms lasting less than 24 hours, and recent ocular TIA was defined as isolated partial or full vision loss due to retinal embolization. Patients with more than 1 neurologic event were classified based on their most severe clinical presentation. The primary outcome of this study was composite rate of postoperative in-hospital stroke or death. Secondary outcomes were rates of in-hospital death, stroke, myocardial infarction, and prolonged hospitalization. Unadjusted rates between cohorts were directly compared with appropriate univariate testing and then multivariable adjusted to assess risk-adjusted relationship between pre-procedural symptom status and outcomes. A total of 9,807 patients were identified, of which 53% were asymptomatic prior to their procedure, 8% were formerly symptomatic, and 39% were recently symptomatic prior to their procedure. Within the recently symptomatic cohort, 69% of patients presented with preoperative stroke, 22% with recent hemispheric TIA, and 9% with recent ocular TIA. To ensure the internal validity of the comparisons made within this study, the distribution of patients presenting with stroke, hemispheric TIA, and ocular TIA between formerly and recently symptomatic patients were compared and found to have no significant differences in the distribution of presenting symptoms. Within the whole cohort, the mean age was 70 years old and the majority of patients were male. Stratified by pre-procedural symptoms, there were statistically significant, although potentially not clinically significant differences in the highlighted categories. Of note, recently symptomatic patients had the highest prevalence of current smokers and the lowest prevalence of coronary artery disease, suggesting some variability in pre-procedural patient selection. A similar pattern of differences were observed within recently symptomatic patients when stratified by clinical symptom. Asymptomatic patients experienced a 1.4% rate of postoperative stroke or death, compared to 3.5% in formerly symptomatic patients and 4.5% in recently symptomatic patients. Unadjusted rates of stroke or death were directly compared, and formerly symptomatic patients had a significantly higher rate of stroke or death compared to asymptomatic patients, while the rate of postoperative stroke or death was statistically similar between recently and formerly symptomatic cohorts. Within the recently symptomatic cohort, patients presenting with a preoperative stroke experienced a 5.5% rate of postoperative stroke or death, compared to 2.4% in recent hemispheric TIA patients and 2.8% of patients presenting with a recent ocular TIA. Direct comparisons of these unadjusted rates were performed, and stroke patients experienced a significantly higher rate of postoperative stroke or death compared to both hemispheric TIA patients and ocular TIA patients, while the rates of in-hospital stroke or death were found to be statistically similar between hemispheric and ocular TIA cohorts. When directly compared to the asymptomatic cohort, all three of the recently symptomatic subcategories were found to have statistically higher rates of postoperative stroke or death. This table demonstrates direct comparison of unadjusted rates of in-hospital stroke or death between recently and formerly symptomatic cohorts, stratified by presenting preoperative neurologic injury. Patients presenting with a recent stroke experienced significantly higher rates of postoperative stroke or death compared to patients presenting with a former stroke. Rates of stroke or death were statistically similar within both hemispheric and TIA cohorts across both recently and symptomatic patients. Multivariate analysis was performed and adjusted for age, gender, race, smoking status, and select comorbidities. Compared to formerly symptomatic status, asymptomatic status was associated with significantly lower odds of in-hospital stroke or death, with an odds ratio of 0.4, while odds of postoperative stroke or death was statistically similar between recently and formerly symptomatic status. Compared with asymptomatic status, the odds of in-hospital stroke or death were fourfold higher within recent stroke patients and twofold higher within patients that had a recent ocular TIA. Recent hemispheric TIA demonstrated a trend towards a higher risk for stroke or death, but did not reach statistical significance. Compared against recent hemispheric TIA, the odds of in-hospital stroke or death were almost threefold higher in patients presenting with a recent stroke. Unadjusted rates of in-hospital secondary outcomes are shown stratified by cohorts. Between asymptomatic and formerly symptomatic patients experienced significantly higher rates of isolated stroke and prolonged hospitalization. Between formerly and recently symptomatic patients experienced significantly higher mortality rates and prolonged hospitalization. Within the recently symptomatic cohort, patients with a recent stroke experienced significantly higher rates of stroke, death, and prolonged hospitalization compared to patients presenting with hemispheric TIA, and significantly higher rates of death and prolonged hospitalization compared to ocular TIA. Rates of stroke, death, and myocardial infarction were statistically similar between patients presenting with hemispheric and ocular TIA. Although compelling and certainly well conducted, this study does have a few limitations that must be kept in mind when viewing the results. First, this is a retrospective review in which 29% of patients within the database were excluded due to missing pre-procedural data, which could potentially have introduced significant bias. Additionally, low event rates were seen in several categories, which may have limited ability to detect statistical differences. And finally, there was no investigation of post-discharge outcomes, which is important to note, given that recent NISQIP studies have looking at carotid stenting patients estimate that up to half of 30-day adverse events occur after discharge. It's important to frame these results within our real-world clinical practice. And as Dr. Setsko mentioned, current guidelines for carotid stenting from major societies such as the SVS, AHA, and European Society do not distinguish beyond the binary classifications of symptomatic and asymptomatic, and do not take into account a formally symptomatic status. The AHA and the European Society have released guidelines regarding the anticipated rates for perioperative stroke and death. And within symptomatic patients, both societies recommend an expected composite rate of less than 6%. Within this current study, recently symptomatic patients fall within this guideline at a rate of 5.5%. However, these results do not account for full 30-day outcomes, indicating that we may not be meeting guidelines indications for patient selection. And these guidelines recommend a rate of perioperative stroke or death of less than 3% in asymptomatic patients, which historically included formally symptomatic patients. Within this study, the rate was 1.4% in asymptomatic patients and 3.5% in formerly symptomatic patients, which suggests that rates of, in asymptomatic patients in previous studies were likely falsely elevated by the inclusion of formerly symptomatic patients, and that formerly symptomatic patients should potentially be treated differently than asymptomatic patients. Given the AHA recommendations for treatment of acutely asymptomatic patients within 14 days, some future studies on this topic may consider further sub-analysis within the recently symptomatic patients, looking specifically at those patients considered acute versus subacute. Additionally, further studies may evaluate 30-day outcomes rather than in-hospital outcomes. However, this may require institutional level data rather than VQI data. And finally, it is important to evaluate the changing role of transfemoral carotid artery stenting as TCAR continues to be explored, as previous studies mentioned by Dr. Setsko have demonstrated lower rates of stroke and death following TCAR. In summary, within recently symptomatic patients, composite stroke death rates were highest in patients with recent stroke compared to those with recent hemispheric or ocular TIA. Formerly symptomatic patients, who have classically been included in asymptomatic cohorts, had significantly higher rates of stroke or death compared to asymptomatic patients. And no significant difference was identified in stroke or death rates between formerly and recently symptomatic patients. These results support preoperative patient stratification based on specific type and timing of neurologic injury, and suggest that distinction between formerly symptomatic and truly asymptomatic patients may be necessary when making clinical decisions and when counseling patients. Thank you, and I will turn it over to the authors and invited discussants.
Wonderful. Jerry, do you want to kick us off? I don't think we can hear you. You might be on mute.
Right, you are. Yeah, I want to just congratulate the presenters. That was a terrific presentation and a terrific summary. I would guess without much risk of being criticized for it, that no surgical subjects had more studies in carotid revascularization. And as you pointed out, some of the studies go back 40 years or even more. It's interesting how some of the items that wind up being used as guidelines in these studies, for example, the 180-day dividing line between symptomatic and non-symptomatic, go back to the NASCET study, and the 180 days, as near as I could tell, was an arbitrary decision, but these things get carried forward because studies want to compare themselves to other studies. So as you read these older studies, there's always lessons to be learned, but everything is different than it was then. And so I think you've pointed out some of those differences, and those are actually very important. One of the most important things you mentioned, I think, and this study pointed out, although couldn't account for it, is that the patients who have neurologic events after they're discharged from the hospital. And many of the vascular papers on perioperative stroke after carotid surgery have been criticized because the outcomes aren't always listed carefully. There was one notable study by Tom Brott many years ago in which he found over half of the perioperative strokes weren't even listed in the medical records. So I think that's an important observation to keep in mind. But we've also known for a long time that symptom status is important. And even in the endarterectomy papers going back many, many years, asymptomatic patients tended to do better than patients with strokes, but there's shades of gray all along. And so it's really hard to make decisions when you're dealing with all of these variables, many of which are not black and white, but gray. So I think it's food for thought. It leaves room for more studies. I think the VQA provides a unique data set because I think the data is relatively complete as compared to a lot of other studies. But as you pointed out, there's no data usually from follow-up or what happens after the patient goes home. So there's a lot of work to be done. And I think this was an interesting paper. And I think as I said, the presentation was excellent. And I thank you for that. There's some questions that have been submitted. One in particular from, I think it was Dr. Eaton, or maybe it was Dr. Glavitsky about, I guess it was Dr. Eaton, maybe doing diffusion MRIs as a requirement before undergoing a carotid revascularization. Do you want to comment on that?
Yes, in 1998, some statistics, greater than 11 million people were estimated to have had a stroke in the US. 770,000 of those were symptomatic. 11 million were first ever silent MRI infarcts. And so it turns out in a cardiovascular health study, in 3,660 adults over the age of 65, 31% showed evidence of silent stroke in neuroimaging studies utilizing MRI. So when we say asymptomatic, we may be missing things when we're categorizing patients. And it's always been an issue when you look at microemboli after a procedure, but certainly if you're going to do this scientifically and stratify people appropriately before the procedure, I think there's a difference between people who have asymptomatic infarcts and those that are truly asymptomatic. And this has been the case in terms of not having this data going back to the 1980s when I entered the field. And I think this new generation, if they're going to start doing more investigation in the realm of asymptomatic versus symptomatic, should finally bite the bullet and use the technology, which is now more sophisticated than ever, to detect these small or silent area of the brain infarcts so they can be appropriately stratified. It does have implication in terms of the complication of a procedure. So I'll give you the best example. In Southeast Asia, they banned carotid stenting when it first came out because there are too many diffusion MRIs showing microinfarcts after the procedure as compared to carotid endarterectomy. And carotid endarterectomy, it's a much more controlled environment in many respects. It may be that TCAR may solve some of these issues, but the only way to answer it is, I think, with biting the bullet and getting the study before and after in a controlled study environment, in hospitals that have the equipment and people that have the skill.
Let me add to that. I think if you look carefully at patients who underwent endarterectomy and had a good outcome by our normal standards, a significant number of those patients will have microinfarcts that are clinically silent. And that's been demonstrated on CT. And as you know, that's not nearly as sensitive as MRI. So even back in the 60s when I was a resident, we were obligated to look in the retina of every patient who had an endarterectomy. It was surprising how many had retinal emboli that were asymptomatic. The study was not published, I might add, but probably could have been. So do you think, let's ask the presenters, does this mean all the old literature is not valuable? It's a question from Dr. Glavitsky.
I'm happy to jump in and take that. But first, I want to thank Dr. Sitsko and Dr. Blakesley Carter for such an excellent presentation of the topic and of our data, and Drs. Humphreys and DiMuzio and Lawrence and Glavitsky for putting on this excellent journal club. And thank you for being able to participate. Yeah, I think that's a great question. And I think that certainly going forward, we need to fix that so that we don't continue to design trials where we divide people into just symptomatic and asymptomatic. Does it mean that we throw out everything from before? I don't know that we need to throw it out, but I think we just need to be more thoughtful going forward, both in how we care for patients and in how we plan these trials, because the risks and benefits may be different at the different levels of symptom status. And we know that, from the onset of symptoms, the clock starts counting and your risk of a subsequent event goes down over time. And yet your risk of a peri-procedural event, or sorry, your risk of having a recurrent event is highest early on, but your risk of having a peri-procedural event goes down over time. So you wonder, is it worthwhile for those people that had symptoms 6 months ago to undergo that, especially if they still have a high peri-procedural risk. So that certainly might need to be looked at. And in terms of, what was the other question? Yeah, well, I think that formerly symptomatic or whatever, I think that designing new trials going forward, definitely we need to factor this in. I think it's important for all of the trials. The other person I want to thank is Joel Solomon, the first author, who for him it's about 2 a.m. right now because he's in the Netherlands, and I'd love to give him the opportunity to throw his comments in as well.
Is he with us?
Yes, I am.
Tell.
Hi.
He was.
Good morning.
Good morning or good night. First of all, I want to thank the presenters and the Journal Club for providing this opportunity. And as to answer the question, I agree with Dr. Schermerhorn. I do not think that the previous studies are obsolete. We used the previous studies and the guidelines as a benchmark to see and to compare the different cohorts in our study. So I think that they certainly have their value. However, going forward, we would advise or suggest that to stratify these subgroups or the cohorts into more specific subgroups in order to provide more accuracy.
Yeah, I think one point that bears mentioning is that a stroke is not necessarily a stroke, in the sense that there are many severities, and this study, like many others, don't really stratify that, and it's a little bit harder to do if you want to do stroke severity scales and that sort of thing, which become pretty cumbersome outside the lines of a well-controlled trial with a lot of neurologic evaluation. But somebody that's got a major stroke, and even though they've recovered, is perhaps not the same patient as somebody who's had a hemispheric event, lasts longer than 24 hours, but then recovers completely. So stratification, as difficult as it is, I think is going to be important going forward. And I think one of the things we learned from the old studies is what we should do next time, what's missing from the old studies. So they're worth reading. I think the historical context is both interesting and important because it helps tell everybody how we got where we are. And the young people are going to
completely.
Young people are going to tell us where we're going. Maybe with Mark's help.
I agree completely. And I think in terms of stroke severity, I'll let Joel comment on that too, because he's done some work in that area also. The pre-op stroke severity and how that impacts outcomes.
Yes, oh wait, we have another question here as well. I'll first refer to the pre-op severity and stroke outcomes. So yeah, we've seen that both in patients with recent symptomatic, who are recently symptomatic as well as formerly symptomatic, that patients with prior stroke were had the most severe rates of in-hospital stroke or death. We also saw that, so we had a in-hospital stroke or death of 5 and 5% in our recently symptomatic group. But like if you compare it to the previous literature, which had looked at the 30-day stroke death outcomes, we saw that we had like similar or like I say similar rates as we did another study earlier, in which we compared the in-hospital. Sorry, let me rephrase. So we did a study earlier in which we looked at the proportion of the 30-day stroke death outcomes, in which we saw that within the recently symptomatic group, half of the 30-day stroke death occurred post-discharge. So what we saw that we had an in-hospital stroke death of 5.5%. And looking at that previous study, we could expect to have, or like it would suggest that we had stroke death, 30-day stroke death, which is double of that with what we found. And this suggests that patients with previous stroke would not be eligible for transfemoral stenting, as it would not be as it would not have the anticipated stroke death rate of below 6%. And looking further at the other question, so I had Dr. DiMuzio, who was asking how is the CREST-2 trials designed with regards to this. So we looked at the protocol of CREST-2, and we saw that there was no stratification within asymptomatic and formerly symptomatic groups in that protocol. So we suggested for CREST-2 and as well as other future trials to also stratify between patients who are asymptomatic and formerly symptomatic.
I can also add, I think Drs. Glavitsky and Dr. Goldstone brought up the point of both the timing of revascularization relative to the symptomatic event, and then also the severity of the preoperative event. We've got an ongoing project where we're breaking it down by the preoperative stroke scale, and then also the timing, whether you're operated on within the first 48 hours versus the first week, second week, or longer. And it's too early to give any definitive findings, but I can certainly say that both of those things are extremely important and certainly have an impact on the outcomes, and that some of our comparisons, in particular with carotid stenting, may be a little bit unfair, because some of those early carotid stent patients or some of those carotid stents were placed for some strange reason, almost immediately after a fairly severe stroke. Now, you'd think that was done when it was done concomitantly with intracranial intervention, but even after we excluded those, there was a fair number of carotid stents, transfemoral stents placed within the first couple of days of a stroke that was a devastating stroke. And as anticipated, they would have a bad outcome.
Yeah, those are obviously important points, and I think it's surprising, not surprising. I guess it's reassuring that even transfemoral stenting has survived and improved. It looked like it was on the deathbed about 10 years ago. I think because it had bad results, and a lot of the surgeons were saying, "See, we can do better with an open operation." But things get better, the technique gets better, the technology gets better, and we're ultimately going to figure out who's the best patient for what particular type of therapy. And then I think that will be the best outcome for everybody. I have to answer, Misty asked the question if I still had my ophthalmoscope. The answer is yes, but it hasn't been used in 50 years. So it's ready for the and antiquarian shop.
Well, thank you all for being here and for the wonderful discussions. We're very grateful to the authors as well as the presenters for taking the time. It's such a great opportunity to really speak with the authors about their work and how they developed it and where they want to see the future go in terms of research. Thank you all again. Remember to join us at the next version, which will be July 14th. It's posted on social media. It's posted on SVS Connect a couple of weeks beforehand. You can sign up and we look forward to more discussion. Have a wonderful night or morning, depending on where you are. So,
Thanks, everybody. Thanks, Misty.
bye.